can't keep up. It's never kept up. And I think if people have focused on that as the proof point to know that they are secure, they're going to find that they will eventually find themselves missing the mark. And missing the mark has tremendous consequences, as we saw last year across the healthcare industry.
Hi, everyone. Welcome back to Season 3 of Trust Versus, the High Trust podcast. Thanks so much for your patience between seasons. We are super happy to be back. For those that are just joining us, my name is Jeremy Huval. I'm the Chief Innovation Officer at High Trust. I'm joined by Robert Booker and Ryan Patrick. Can you both introduce yourself?
Hey, everyone. Robert Booker here again with you for our Season 3 first episode. So excited to be back behind the microphone talking about something we all love to talk about.
My name is Ryan Patrick, Vice President of Adoption at High Trust. I want to thank Jeremy and Robert for so graciously inviting me to join them on the podcast. I've heard nothing but raving reviews from the audience and the listening members out there, and I'm just really ecstatic to be a part of it. So thanks.
Yeah, and Robert and I were agreeing with yourselves like we often do, and then all of a sudden realized we talk amongst each other too much, and we don't give Ryan enough microphone time. And so Ryan's going to be joining us on several episodes this season, and he's got a wealth of knowledge in the high trust arena and cybersecurity compliance and risk management, and came from a high trust external assessor firm, and just brings a lot to the table in terms of perspectives on the topics we're talking about. So we're really excited to hear more from Ryan this season and share the mic a little bit. So that's something to look forward to. So a lot's changed since we last recorded. It feels like the industry we're in is an ever-moving target of things to try to keep up with and talk about. And obviously AI, we talked about last season, and it continues to make an impact in the business world. So this season, we'll be talking about a lot of stuff, including AI, but not exclusively. We'll talk about multi-compliance and how organizations are moving away from SOC 2 to higher assurance offerings, and just a general collection of what we think are exciting topics and certainly impactful to those in the high trust ecosystem, as well as those who have to manage IT risk and try to stay abreast of the latest in IT compliance. Today, we'll be talking about the Notice of Proposed Rulemaking that was released by OCR around HIPAA very early in 2025, late 2024, and what it means for those that have to be HIPAA compliant, both covered entities and business associates. It's more than just a rebrand. Robert, can you help maybe frame the conversation?
Yeah, I'd be delighted to, Jeremy. I'm actually reflecting on the Season 2 inaugural episode we did just about a year ago this time. And as our faithful listeners will remember, we were talking a lot about a major event that just decimated the healthcare industry. One of the major suppliers to many health plans and health providers across the industry had experienced a significant cyber event. Eventually, it was classified as a breach and a loss of information. But I think most importantly, it was a tremendous disruption of service, not only for their operation, but for the industry as a whole. We reflected on that with our colleague, Steve Perkins. And the things that happened after that, which we didn't really talk about during the year, were a very significant number of congressional hearings, both with the House of Representatives in the United States and the Senate. Testimony that was given, I think, very, very transparently by the victim company, and a lot of conversation by industry experts and others with congressional leaders, and I suspect as well with the regulators about what was the impact of this event, how do we want to think about this event as an industry. And there's certainly people like us that really have spent so much of our life and our livelihood focused on helping people make sure they're good enough. How do we build trust and assurance in a system? We looked at this and we said, while companies do the right things, we're never going to be perfect. There's always threats out there. We always have to continually sharpen our weaponry and continue to stay focused on the game. And we too are saying, what is the opportunity here? So that at least from a federal perspective, I think resulted in a lot of reflection by the primary regulator for the health industry, which is the Department of Health and Human Services, and more specifically the Office of Civil Rights. It was really a culmination of an expectation they had set, I want to say probably 3 years prior, that they were going to eventually update the regulatory framework for protecting the privacy and security of health information in the United States. And that would that would result eventually in something that some of us have euphemistically referred to as HIPAA 2 or a next-gen HIPAA. I've heard all kinds of people characterize it as those things, none of which are the official names for this. The government uses longer terms. But, the whole intention has been to focus on the opportunity to look at the regulatory system that provides guidance to health care providers, payers, and other regulated entities, as well as their business associates, and to ask the question are there new things that should be required in the regulation, in the rule, things that organizations that are doing cybersecurity or maybe haven't been doing enough cybersecurity need to do more of? And that really created the genesis for a very lengthy, a very significant body of work that was published by the Office of Civil Rights, actually just prior to the new year. Actually, it was just prior to the January of 25. They said, here it is. We're going to publish it in the Federal Register shortly. It came out immediately after that. And that was, of course, just before the election of the new administration, or before the inauguration of the new administration under President Trump. It seems like so much has changed in Washington in the last months around all kinds of things in the country, many of which are things that have nothing to do with what we're talking about today. But included in that is kind of a march towards what is the future of healthcare going to look like from a regulatory perspective. And it's the questions are so much broader than security. But for the purpose of what we care about and what I know our listeners care about, this is right. This is about doing the right thing and making sure the right things are done from a health services perspective and in support of the organizations that pay for health services in our company, the providers that provide that care, and the associates that make sure all of the big machine of healthcare operates successfully and that payments get made on a timely basis and all of those things.
So let's dive into that a little bit. If Ryan, if you don't mind, can you maybe let us know if the goal of this Notice of Proposed Rulemaking for HIPAA or HIPAA 2, are the goals substantially different than what HIPAA originally set out to be in the cybersecurity area?
I don't think so, to be honest. I think the intent is probably somewhat the same. It's more of a refresh of what the safeguards have been historically asking versus the way that technology and the threat landscape has evolved in the 30 or so years that it was originally enacted. So I think the intent is still to protect patients, protect patient information, and try to support and facilitate better care for those patients based on the whole ecosystem. The challenge really is going to boil down to is what is proposed going to be enough moving forward? And I think we'll probably dive into that a little bit more as the conversation goes on. But Robert, I think hit on a really important point here, that the Notice for Proposed Rulemaking, it may not go anywhere, to be honest, but something's got to change. Right now, HIPAA's not enough as far as the safeguards that it's telling organizations to have in place in order to meet the intent of the original rule. And we're going to see something, whether it's a federal mandate or an update to the regulations or something that happens kind of on its own, something's going to change because, and we talk about this all the time, internal to high trust, healthcare is woefully under-resourced and completely overwhelmed with what they're trying to do and the resources they have available to in order to do that and protect those environments and that data adequately. So I guess to circle back on your question, Jeremy, I think the intent is generally the same, but the refresh and the update to the safeguards is much, much needed because HIPAA, the way it's written today, does not protect organizations. It doesn't give organizations enough information to appropriately implement the safeguards and stay on top of what's happening within the threat environment and from a technology perspective.
Right. And you mentioned the age of HIPAA. So is it safe to think about this as sort of a bit of regulatory catch-up, as it were? Or should we view this as maybe forward-looking in nature and maybe an opportunity to really change the way things are done? Would you characterize it as catch-up or kind of future-proofing the industry?
Honestly, in my opinion, it's catch-up. I mean, there's some pretty obvious things that are that we're missing in the proposal, probably most notably AI. There's nothing really in there about AI, and that's the way all markets, all industries are kind of moving, and there's nothing in the proposed rule. So I really think the things that are in the proposed rule, the market and the industry, healthcare specifically, obviously, have already been doing on their own. And this update to the security rule is just meeting the market kind of where it's at. So when you look at the different types of really big ticket items, MFA needs to be in place. Risk assessments need to be done every single year, whereas the rule, the way it's written today, say, do initial risk assessment anytime there's a significant change within the environment. Now it's saying you need to constantly be revisiting that risk. And then it's also talking about third-party risk management and working with your vendors and being more collaborative and those things. The market's doing all that stuff now. Now, I would offer, or I would assert that not everybody in healthcare is doing this or doing it well, but that shift is happening. That momentum is building. And in my opinion, the proposed rule is just playing catch up.
I so agree with you, Ryan. And I think we actually look at the actual rule is about 20 plus years old now. And you look at technology and you look at the fact that these devices we carry in our hands, the iPhone, the iPod, the technology we use did not exist at that time. So the one argument would be, well, HIPAA is risk-based, and if you follow a good identification of your assets and you identify the technology that services those and the risk to that technology, you can always be current. But I think the challenge is, and it's not just, to be fair to HIPAA, it's not just HIPAA. I think many regulatory regimes, and frankly, even commercial regimes like PCI, have suffered from the fact that they are an invitation for regulated or covered entities to say, I will meet this bar and that bar will be good enough. And then the challenge I think that things like HIPAA have, or anything is tied to this kind of a regulatory system, is they're based in a model that has to be static because of the manner in which these rules evolve. So think about this, the amount of evolution that's happened in 20 years in the health industry, not just technology, but healthcare plus technology. And this is really arguably the second change to the rule. The first was the implementation of the breach notification rule, which was kind of a sidecar on the original security rule. We're just now looking at this. It can't keep up. It's never kept up. And I think if people have focused on that as the proof point to know that they are secure, they're going to find that they will eventually find themselves missing the mark. And missing the mark has tremendous consequences, as we saw last year across the healthcare industry. And so I think it isn't solving the problem. It is trying to play catch up. And I just think we're truly missing it. And then there are other things that bolt on, like HICP or hiccup, cyber performance goals. There are these efforts. And I know they're so well intended. I know good people and caring people are working on these things, but they keep trying to build more regulatory layer into this with nothing designed to actually solve the root problem, which is people must know their systems are tested, validated, and assured to be good. And without a system that does that on an operational basis, you're playing catch up always as an operator.
And I think you hit on some really important points there, Robert, that I want to put an exclamation point on. The role of government is not to be as up to date as the commercial market is. I mean, it's just through pure bureaucracy and politics, it's never going to move at the speed that the commercial markets can move. And I think to your comment, I think the second point I would offer around people need to understand that they have to kind of do more than what the regulation tells them. There's a challenge in there in that when you think about the dynamics of healthcare, sure, there's huge multi-billion-dollar organizations out there, but a large chunk of healthcare is underfunded and under-resourced. So they don't really have the expertise. And that's the reason why they look to government to tell them, well, here's the minimum bars, because they don't have the resources, the money, the time, the people to be going kind of above and beyond. And I guess my last point is, when you look at what's happening within the federal government right now with budget cuts and the way that DOGE is coming in and kind of cleaning house to a certain extent, entities like FedRAMP, the FedRAMP PMO, are actually now trying to go out to industry and say, help us solve this problem and help us figure out a way to do this more efficiency, remove the redundancy without sacrificing any of the value, the trust, the assurance, at least in our world from a cybersecurity perspective. And I feel like HHS probably could take a page out of the FedRAMP book from that perspective. Sure, there's going to be an update to the security rule, but why not look to the commercial markets and start to figure out ways to partner with them to strengthen what the security rule in this case is ultimately trying to do without waiting for the government to be able to do it on their own. Do you know what I mean? Like it's like, and this is going to sound self-gratifying, but why wouldn't HHS come to HITRUST and say, help us solve this problem? You guys can move way faster than we can, and you've built a mechanism where assurance can be trusted and the assessment can be trusted. We're never going to be that centralized authority as HHS, whether it's OCR or some other agency, to weigh in on these things and make sure that these health systems or these healthcare organizations actually meet the bar of HIPAA.
Robert, HITRUST was one of the nearly 5,000 organizations that provided comments to the Notice of Proposed Rulemaking, and I think you authored that response on behalf of HITRUST. What's HITRUST's perspective on this, and what was in our commentary back to the authors of the Notice of Proposed Rulemaking?
Yeah, I think to be fair, I did not read all of them, but I read a good number of the responses, and I think they ran into different buckets. The vast majority of responses were addressing something Ryan just spoke about, which is the inordinate burden that healthcare companies face today just in doing patient care, and the fact that getting this wrong was going to be a tremendous impediment to doing good healthcare in our country. So a lot of people said, please don't do this to us without more consideration. So I agree with that point. We chose not to take that point. We actually chose to respect the spirit of what was being sought. And the spirit was, how can we make the system better? So we focused upon the things that are really absent and sorely missing from the security rule, which are systems of validation and systems of testing and systems of assurance and certification. The mechanisms that organizations can use based on existing science that will allow a regulator as well as a relying party of any kind, whether it be as a business associate, a covered entity, a trading partner, to know that the organization that is working with them as representing themselves as secure is actually as secure and validated as is possible given the world today. So we talked a lot about the foundation of assurance and the foundation of a model that could, in fact, lead itself to something that would provide the outcomes that OCR and, frankly, the industry as a whole are seeking, which is good cybersecurity and good privacy. But the second thing we talked about as well is this problem of how do you keep up? And Brian said it very well, is that the government, because of the nature of how rulemaking happens, will always move at a slower pace. That doesn't mean that government systems have to be dated and can't be current. And that is the partnership opportunity. The partnership opportunity is to work with assurance systems that say the broad requirements of the rule are you need to do these important security principles and meet these security obligations. As threats change on a regular basis, in our case, even quarterly basis or near real time, we're constantly looking at what are the new risks, what are the new attacks, what are the new things that need to be considered. How do you think about the implication of generative AI as an important part of your tech fabric, and you actually build that into your security operating model, and you start to validate and test and grow your security maturity to address those new needs and those new threats? There is a way to do that is a public-private partnership, and I think we wanted to encourage the agency and the department, as well as encourage the leadership of our country, to really recognize that there are systems out there. And while HITRUST, we obviously believe it to be the best, and we think we have good data to show that it is, we're agnostic in this podcast. We want to talk about the fact that it's really an opportunity to use the best. And there are other government systems such as NIST and other technology such as cloud service providers that we also think have high value, and we wanted to promote those principles. So for example, inheriting security controls from a cloud service provider and allowing the small and marginally funded healthcare entities to go buy their security framework from somebody like a Microsoft, like an Amazon, like a Google, and know that it's validated, it's tested, and it's hardened, and it's proven. Those are the ways that you scale this problem. And I actually maintain that if we change the thinking in the industry in the right way, we will actually solve the bigger problem, which is how do healthcare entities do security at lower cost, lower complexity, and higher outcomes. So we talked a lot about the spirit of that. And our response, Jeremy, is available, and we invite anybody to read it, and we invite to be challenged on that. I think it's a debate, and it's an important debate for the industry and an important debate for all of us that care about this. And it's so important for us to just lean in as leaders across all parts of healthcare, all parts of the regulatory system, and become part of the solution together.
Yeah, well said, Robert. And part of our exercise in preparing for that comment was to reconcile what is in the rulemaking or proposed, kind of what's in a high trust assessment today. Are there any notable gaps in coverage or conformity levels that someone adopting the high trust CSF would have if there was a magic wand and this thing was implemented tomorrow? Do you recall the outcome of that reconciliation? Did you have any takeaways, or Ryan, perhaps?
Yeah, Jeremy, we actually looked at this when that very first draft came out in mid-December, and we knew right away that people were going to ask the question, like, do I have to start over? Do I have to leave what I've done with high trust behind and go start with something new in order to actually address this? And we were gratified to find that the foundations were still the same important controls. And so if you look at a high trust certification with the HIPAA security rule included or tailored in the scope and in the requirements of that certification, if you've already achieved high trust certification with the HIPAA security rule selected, you already have covered about 95% of the new rule, that is the new requirement, capabilities. Clearly, there's 5% to be closed. It has a lot to do with scope and has to do with third-party risk management, which we would fully and passionately agree is an important problem to solve. But yeah, organizations that have started with us and have played with us in that process are already ready. And we think those organizations will have a much smaller gap to close when and if such a rule would come to be real.
Yeah, absolutely. And I think one of the things that I noted in my read of it was where the current HIPAA security rule is descriptive rather than prescriptive. This one does have some prescription in terms of frequency of performing controls. And in that 5% delta from the current I1 plus HIPAA security or R2 plus HIPAA security, there are, I think, gaps in prescription in addition to what you mentioned. So, for example, the proposed rulemaking calls out like very specific time windows, like perform your vulnerability scan every 6 months, 72-hour backup recovery objective, stuff like that. And so that is a change in tone in HIPAA from descriptive generally to maybe more prescriptive in this case, which isn't necessarily bad, right? But I don't know that they'll ever hit the nail on the head in terms of perfect prescription for everyone, because it's a very large addressable market they have to satisfy here.
That is the intention that was trying to be met with the rule. Was we clearly know there was a problem. The issue that happened last year impacting the health industry was an impact to a single company's operations that probably touches the vast majority of healthcare in our country. By my recollection, some of those core systems were well over 30 to 45 days in recovery before they were back online. And when you think about the fact that there are organizations that cannot submit claims for payment and cannot receive adjudicated claims and then subsequent payment for services, and they were looking at possibly 45 days to get those payments back again. There are companies that were really at risk of going out of business. I'm talking about now small hospital systems and physician providers that need that cash flow to pay their employees every day. So it was a big deal. So the regulatory, I think maybe the reflex or the response was, okay, 48 hours. Let's make sure those core systems can be recovered in 48 hours. And while I respect so much the spirit of it, like setting 48 hours as the expectation is certainly admirable. I think the frank reality is you have to look at how the systems are built and start to ask the question of, is that even an achievable goal? Or do you need to do a better job at business impact analysis, identify those core platforms, make sure there's duplicate and redundant pathways available, which certainly could be part of that as well. But those things aren't fully prescribed, and they've just said 48 hours to recover. And I make the argument that I can spend so much time chasing the intention or the obligation that I actually miss the delivery of the actual outcome, which is my systems will deliver services and be recovered quickly, even if those services fall to an alternative provider or some other mechanism which is not necessarily desirable but is acceptable while they're recovering the larger system. So it's just the kind of thing that happens is when all of us that are legal minded or regulatory minded write these rules, you have to really think about what will people interpret them as being and will they actually achieve the goal we're seeking.
Robert, when I read the proposed rule, the original intent of the security rule was really focused on the confidentiality of data, right? It was very focused on breaches, maintaining chain of custody of that data, so on and so forth. And you started off talking about the significant event that happened in healthcare last year, and it's the pervasiveness of ransomware, which it's kind of a double whammy. They're siphoning data out, but it's really about something you just said, which is the availability of services more than anything else. I mean, that was the big thing about change last year is patients couldn't get their prescriptions. Small practices were not getting paid. So their viability as a business, as a clinic was actually in question. So do you feel that the tone of the current proposed new rule is still really focused on confidentiality? I mean, granted, it does have availability safeguards in it, but in reading it for myself, I still felt like it was very focused on confidentiality. I'm curious what your thoughts are.
I'm not a lawyer, so I'm not going to try to play one, but some of this comes back to the authority that is granted in the law that OCR is acting under. And so, as you well said, Ryan, HIPAA was focused predominantly on the protection of patient data, an admirable goal and a goal that we all care about. So I think that is the genesis of it. But if you actually look at, again, the 20 plus years since these things have emerged, while nobody will be happy to have a breach, I mean a true breach where data is disclosed, and organizations will rightly have enforcement actions because they let those things happen. I think the real risk to the industry is the risk to availability and to some degree to confidentiality as well. But the availability risk is really what is the predominant impact. And again, I think I'm so broken record when I say the fact that things have changed so much in technology. When healthcare was being delivered 25 years ago, you didn't have the technical systems that we lean on and rely on every hour of every day in healthcare. You went to the emergency department and your doctor came in taking notes in a paper chart, and then somebody would transcribe those notes later. It would eventually end up in a mainframe or a mid-range system somewhere, perhaps, or more likely end up in a paper chart sitting on a shelf somewhere. And so that was the focus under which the rule was created. And now, if you walk into an emergency department, depending upon what generation your provider is, some of the young generation of doctors, I mean, they are adequately and appropriately being trained to lean on their EHR systems and the EMR systems. And this is how I access the protocol and what I need to do. And yes, they can do emergent care and they can stabilize the patient. But when you get into complex morbidities and delivery of care, it's all about the system and the doctor working together. And without that system, emergency departments close, communities go on bypass, the ambulances are sent to the hospital 20 miles down the road. Unfortunately, patients have perished because of that. So it's just such a different world, Ryan. And I'm just so passionate about it as a technologist delivering to healthcare. I think your question is super, super insightful because while HIPAA is written in the context of the law, I could make the argument that there needs to be a rethink about the whole basis of it. I'm not arguing for that because we operate in what the law provides here, but I think the problem is much different than it was 25 years ago.
If you were to imagine a world where this proposed rule was passed as it's written today, which is very, very unlikely to happen, we'll talk about that a little bit later, what would be the hardest thing for an organization to comply with in this new content? Did any one thing jump out to either of you?
I've got a couple in mind. I think there are things as well, Jeremy, like understanding the scope of the system. One of the few places I think that the rule is prescriptive is around how do you do asset discovery and identify the scope of your system. The rule has always been based on where is electronic protected health information well, actually PHI more broadly if you look at paper, but where is that data and how do you protect that data? And regulators have asked us to draw a box around PHI, ePHI, and secure that box. And the frank reality is organizations, and I know this from personal experiences, organizations spend thousands of dollars, hundreds of thousands of dollars doing very extensive analyses to document their IT systems in a very complete way to meet the spirit of the rule. And they would have to do more of that under the new rule. I can make the opposite argument, which I will make again and again. I'm happy to be on record with this, is if you look at the way technology is delivered in healthcare today, every single bit of healthcare is technically based. So what, if you want to secure a system from an ePHI perspective, secure everything. And I know that sounds really impossible as well from a tech perspective, but you know what? I can't draw a box around this part of the system has no protected health information in it. Not in a contemporary IT systems in healthcare. It just, everything has ePHI. So we're spending thousands, if not hundreds of thousands of dollars to document the boundary of a system when we could simply say, you know what, if you want to stipulate the entire system's in scope and you want to take on the obligation, good on you, because you're probably going to spend more dollars on security and on assurance of that security than you are trying to document what is out of scope so you don't have to do security for it. And I can make the argument all day. That's where the seams emerge in technology fabric and systems.
I would offer that, but that's not a new requirement, right? The original rule wanted to know where ePHI or PHI was being housed. If you got audited by OCR, anytime since the rule has been enacted, that's the first question they ask. Show me which systems have ePHI. The next question they ask is, show me the risk assessment you did on those systems. So I don't think the new rule is, it's probably
Or prescriptiveness to it. That they want a more detailed asset inventory. They want a more detailed network map. And they want you to refresh that every 12 months. And for organizations of very complex nature, that is a very complex thing to do. And even organizations that are moderately complex, but you're correct in that you had to do this anyway. My read is that this is going to be very difficult to stay on top of, more than it already is, and you already should be doing it to get it right. However, I've seen a lot of organizations say, look, even on our help desk ticketing system, we cannot guarantee PHI is not going there. Therefore, we're going to draw this, everything is in scope boundary. We have to assume everything is going to process ePHI. Therefore, we will enforce an appropriate level of security to meet that associated risk. That is something that people do today. And the burden of doing a follow the data asset discovery exercise in a very, very, very large organization would be very, very, very difficult.
I agree with everything you said. The argument I have tried to make in the past, unsuccessfully with regulatory partners, is I would like to say this organization, from a scope perspective, every system is in scope from an electronic protected health information perspective. And I will take the obligation to secure that entire system with stipulation that it is all PHI. That is not allowed under the rule. The rule does not allow me to say, I will tell you it's all PHI, because that somehow from an enforcement perspective seems to be a attempt to sort of evade what the rule asks for, which is a clarity of scope and a clarity of asset inventory. And again, I don't have a problem with saying, here's my IT inventory, it's all PHI. But that's what I was seeking. I'm seeking the fact that we can say that based on how technology operates today, I'm willing to say, as long as I'm not trying to carve out stuff and say it's not protected and it doesn't have to be protected, I should get the latitude to say, I want to spend my dollars securing the system and not chasing an inventory alone or first.
I totally agree with you. I love the premise that you mentioned around just draw the box around the entire organization. Now, whether OCR is going to appreciate that, I guess that's to be seen. But Jeremy, you made a comment about large organizations and how complex they are. Actually, I think the bigger issue is on the opposite end of the spectrum. Rural hospitals are in big trouble. And they don't have the resources. They don't have the people. They don't have the expertise. They don't have the money to hire somebody to come in. And they're not as complex as a really large health system that has 30 to 100 hospitals, but they're still going to be relatively complex. And they just do not have the capability to meet the intent of what the rule is trying to do. So to me, that's the biggest risk point within the industry at large.
Do we have any perspective on the total burden that this proposed rulemaking would introduce to the healthcare industry in the United States?
The focus and the prioritization in our government right now is on things other than cybersecurity and healthcare. And while I don't believe that means that the government does not care about patient confidentiality and availability of the systems that we regulate across our country, I think it is not a zero-sum game in terms of people and resource. So if I have to spend time focusing on other initiatives that may have higher priority, like, for example, retooling the research institutions across our nation, which are equally viewed as important, if not more important, by this administration, I think they get the priority right now, and probably they'll get the lion's share of political capital, if you will. Ryan has mentioned the fact that there's a significant efficiency debate in Washington right now with the Department of Government Efficiency, or DOGE. And I know that does certainly impact all departments, including HHS. And some people have also just taken the opportunity to retire. There have been retirements at NIST. There have been retirements from OCR and HHS. So I think there'll be new leaders entering the space, and they'll likely care about this problem because they own the problem of doing it right, and they'll probably re-engage with us. But I think less likely than I would have said a year ago that this would move forward right now. But these things sometimes have huge political overtones, and as much as I hate to suggest this could happen, another major industry event that keeps people from getting health care and being able to access their emergency room when they've got a significant health crisis happening, has a real way of focusing our nation and galvanizing our political leaders. And this is on the shelf, and it's in written form. And I know lawmakers, both House and Senate, continue to care about this problem and are looking at ways to provide further legislative direction to all parts of the government and create frameworks and expectations that we get better. The other thing is there's a co-partner in this, and I keep mentioning OCR, but the Department of Homeland Security with CISA has also been an active partner in cybersecurity for all critical infrastructure, of which healthcare is certainly one of the more critical things in our country. CISA has had a lot of changes in the people that are going to be sitting in the organization as well with the new administration, and I think those people are still getting their toes under the desk. And my suspicion is you will kind of see in the next probably quarter to 2 quarters what the priorities will be there. And I think I'll have to take all those long words, Jeremy, to say it's a wait and see, but I think less likely than likely at this point. Jeremy, how do we think about this as an opportunity for the industry to continue to do what we've always done, obviously high trust, but what's the opportunity as we look at the uncertainty here for us to lead from the front? I mean, do you think about how do we evolve the model of assurance? How do we continue to do more and interesting things like cyber threat adaptive? And what are the opportunities for us to, absent a regulatory decision, what can we do better and what should we be focusing on?
Yeah, absolutely. I think about the system of assurance and the system of how organizations can basically ensure that there's good security up and down a supply chain. And I reconcile sort of what I think right looks like and what I think is scalable with this approach and this Notice of Proposed Rulemaking, which to me I read as sort of more of the same, more of yet another set of static content that I have to try to achieve and demonstrate conformity with. And what I think we need is something maybe more drastically different. Maybe instead of specifying, here's a static list of the things that we think we have to all be doing to ensure like a minimum acceptable bar is enforced throughout the entire healthcare security industry. Multi-factor, tell us when you had a breach, just this static list. Maybe we do things differently. Maybe there is a world where we have a criteria-driven standard instead of a static prescriptive standard. And what I mean by that is, wouldn't it be great if there was a version of HIPAA that said, look, the way you tackle the problem of cybersecurity and what has to be in your program is not do X and Y and Z and 1 and 2 and 3, but achieve these criteria. 1, for example, implement a framework that is continually evolving as the cybersecurity threat landscape changes. Also, implement a framework that allows you to very clearly specify what is a shared responsibility and a partial responsibility, and inherit assurances from service providers where it makes sense. And also implement a framework and an assurance methodology that allows you to have reliable, demonstrable achievement between organizations, i.e. a certification or authorization to operate. And also, wouldn't it be great if that framework, that one of the criteria of the framework you're expected to implement is sort of tailorable to the inherent risk profile of the organization? Instead of trying to say, here's a collection of what we all have to do, say, look, this has to be tailorable. So very small organizations can sort of specify they have different inherent risk levels than the largest and most complex organizations, and therefore the actual controls they have to implement are suitable for their level of inherent risk. And if you think about these as different aspects that would have to be met in the organization's chosen cybersecurity framework, it's a different way of approaching it. And to me, I think that's maybe the better way to future-proof this thing. Because what I read in this Notice of Proposed Rulemaking is more of the same. There's so much stuff to fix in the very old version of HIPAA that we currently live with, but we're fixing it by maybe making the same mistakes that were made 20, 25, 30 years ago when this thing was originally conceived. That's kind of how I think about it. And I'm a bit biased because a lot of the criteria that I just described, HITRUST has been working to implement inside of our own system of assurance.
Yeah, I think it builds on a foundation in my mind. And we were very thoughtful in our response. We've offered to say, we'll sit down, and we'd love to sit down with regulators and lawmakers and others and say, hey, here's our view of how we could make it better, how we could evolve it. And it's some of those things you mentioned, Jeremy. Some of those are currently available. Some of those are future things we're looking at. All of them, I think, make this so much more efficient and more capable. And so I will make the argument again, we have to lead from the front as an industry. The people that care about good patient safety and healthcare need to be involved. We need partnership, and we need to be all working together to find the one voice that we can have to move the ball and to help us be much more resilient and make sure that the goal of compliance actually achieves our outcome, which is, in this case, a resilient and secure system.
Yeah, well said. And that is a good note to wrap on. So again, like to welcome Ryan to the podcasting crew, and like to thank everyone for joining us on this initial episode of what will hopefully prove to be a very exciting season of HITRUST Trust Versus. Till next time.
Thank you all. Welcome aboard, Ryan.
Don't forget to leave a review on your favorite podcast app and subscribe.